with a special interest in disorders of the immune system. Primarily recipient of the transplant, an educator for an entire career. He is board certified in infectious disease and is currently the head of the infectious disease and public health at Share India. Sir is a clinical professor of medicine and surgery at the University of Illinois at Chicago. His work over the last 3 decades, he has a lot of research work, laboratory research in the antimicrobial resistance and the molecular genetics. He has a translational research in infectious disease, diagnostics, clinical research in transplant infectious disease, HIV epidemiology, antimicrobial development, lot of work on the fungal infections, lot of fungi he's working on, and his work is providing technical support to the NACO, National AIDS Control Organization, Ministry of Health and Family Welfare, Government of India, and has been funded by the United States Center of the Disease Control and Prevention. He is a full bed specialist. His work has been recognized by the several awards and excellence in teaching and leadership. He is a member of the Committee of the Practice of the Implementing Public Policy, Harvard Kennedy School of Government. And I have a personal experience with, I'm privileged to have work as an observer in University of Illinois under his in his department and under his guidance. So, sir, we welcome you here, and we are very happy you are here. Just please, we are waiting for your presentation.
Thank you very much, Ruby. It's really a great honor and privilege to be with you, the East Delhi Physicians Association. So I'll start my presentation. So let me start sharing. So before any presentation, I always like to start with a small prayer. Lokaha samastaha sukhino bhavantu om shanti shanti shanti. Loosely translated, it means in all of creation, may joy happen and let there be tranquility. So the objectives of the presentation is to discuss the differences in epidemic compared to last year, discuss place of vaccine in combating the epidemic dynamics and why vaccine, the role of boosters and pediatric vaccine. So compared to last year, there's been an enormous increase in the number of patients. Entire families affected at the same time. And that raises the question, who's left as a caregiver? So everyone knows a friend, neighbor, or family member who's become critically ill or expired. A much larger number of symptomatic patients as compared to last year. And a larger proportion of infected individuals progressing from milder to severe illness. A much more rapid progression from milder to more severe illness, telescoping. A larger proportion of individuals taking very long to recover from symptomatic illness with persistent elevation of markers of inflammation. Very frequent recurrence of symptomatic illness in people a few days after stopping anti-inflammatories, and many individuals presenting after 1 dose and some after the 2nd dose of vaccine with recurrent infection. A small number of people having post-acute sequelae of COVID, primarily chest syndrome, tachycardia, disabling fatigue, cognitive dysfunction, so on and so forth. There's a small number of people who are dying due to sudden death. The cause is very poorly understood. There's been an explosive increase in demand for high-resolution CT scans, explosive increase in demand for remdesivir, and also an epidemic of treatment with very questionable regimens like doxycycline, ivermectin, high-dose vitamin C, vitamin D, zinc, high-dose steroids, antibacterials, proton pump inhibitors. Now, I've personally taken care of over 500 patients the last year and a half. And what I'm impressed with is that there are a large number this year. There have been a large number of patients with lots of RALs in the lungs, not necessarily hypoxic. And very interestingly, most of these are patients who have been on doxy and ivermectin with persistence of symptoms. A lot of public hospitals have been overwhelmed. And even public hospitals were not consistently providing dexamethasone and anticoagulation to patients requiring supplemental oxygen. So the questions that arise is, how is this illness caused by COVID-19 different from previous epidemics of SARS and MERS? The case fatality ratio, ease of transmission, contagiousness. clearly, despite the fact that SARS had a case fatality ratio of 10%, MERS 30%, COVID is a bigger problem because the denominator is so much larger, even though the case fatality ratio is substantially below 5%. So the question is, why did the epidemic grow so out of control? And what is so unique about India compared to the United States vis-a-vis the epidemic dynamics? And what's the difference between a first wave, second wave, and is there going to be a third wave, and so on and so forth? What's the role of variants? Will vaccine work against new strains? And what's the reason for so many deaths? Lack of oxygen, lack of hospital facilities, trained staff. When will things improve? How? And how can we, what do we know? What do we do now to address the COVID epidemic in India, the impact in India? Was the current catastrophe predictable, preventable? How and why? And can something like the COVID pandemic happen again with another pathogen? How and why? And what can we do to prevent anything like COVID happening again? So this is a work that we did last year looking at a simple SIR model of epidemic dynamics projection in the state of Telangana, where we used a model to suggest that 36% of the population would have COVID infection by the time we reached, September of last year, so assuming an R0 of 3. So using those assumptions, we projected that 36% of the entire population of Telangana would be infected, and pretty much a similar kind of statistic would be seen throughout India. But here's the reality. This is from yesterday, from Our World and data, right? So you see that our projections way underestimated the R0 and the total number of people infected. Why did that happen? So look at this, what's going on? This is the rolling average throughout the world. And throughout the world, you can see it is still a huge problem, with India still one of the areas that has been significantly affected. And here's the daily rolling average. Fortunately, it appears now that the new cases are beginning to taper down, maybe. But, this is the data for the COVID vaccine, and this projected COVID vaccine, how many will be vaccinated in the near future, okay? So this is where we are, and this is where we are headed. Now, why does all of this happen? It's very important to understand what we call a logistic map equation. What the logistic map equation tells us is when the R0 is around 3.44949, the epidemic becomes cyclical. So our R0, I would suggest to you, is way beyond 3.4499. So that means that no matter what we do, the epidemic is going to be cyclical. What can change the natural history of this epidemic from becoming cyclical is probably vaccination, okay? Now, the other thing that is very important to understand about COVID-19 is because it replicates into such phenomenal numbers, and because the transmission is so high, it rapidly evolves into a viral quasi-species. What a viral quasi-species means is that in the entire population, there are multiple subpopulations, and selective pressure will allow selective subpopulations to emerge, which will have differences in virulence, transmission, and also the ability to evade immune obstruction that is conferred by vaccine or evade the activity of drugs, which is why I will predict to you that no single antiviral will ever work against COVID-19. No single antiviral has yet shown any significant efficacy, and that includes remdesivir. I know that currently there is a great deal of excitement about molnupiravir, and I will predict to you that molnupiravir will work only and only in very early mild cases. It will fail to work in moderate or severe cases because, very simply, it is like Karna's Brahmastra. In the time of the greatest need, it fails. And the reason for that is that the body itself can reduce the viral load by 3 log in about 1 week's time. no drug, no antiviral drug has been shown to do that. Now, the only things that have been shown to reduce viral load significantly are the antibody cocktails. So unfortunately, what happens is in those individuals in whom very high degree of replication consistently keeps ongoing, and this is particularly true of immunocompromised hosts, an antiviral fails after the first few days, which is what we have seen with remdesivir. Remdesivir alone fails. This is why you can see that there is no difference in efficacy between 5 days and 10 days of remdesivir. So the people who are destined to get better and benefit from an antiviral will do so very early on, because the body's own immune system will work in concert with the antiviral and bring the viral load down. The other problem is that in COVID-19, antivirals per se are not the entire story, because there are many individuals in whom, despite the fact that the viral population has been controlled by the body, there is a persistent ongoing inflammation which essentially burns down the entire body. And until that inflammation is controlled, we cannot save that patient. So I think that the optimum strategy, again, in the future will be in each and every individual to accurately phenotype them, to identify individuals who absolutely need antivirals and possibly combination antivirals rather than one agent alone, and also to understand which individuals will absolutely require anti-inflammatory, with again further phenotyping to understand which individuals require what type of anti-inflammatory and which individuals are unlikely to respond to anti-inflammatories alone and actually will require some more significant immunomodulation. So the conclusion here is, in all likelihood, we will see the epidemic numbers decline in the first few weeks, and then inevitably cases will rise within the first few months of the decline. And the scientific reason for this is the logistic map equation. So like I said, if we are able to vaccinate over 75% of the population, including children, maybe we can change the population dynamic, the epidemic dynamic. Now, the unique challenge in India is that in the age group of 0 to 14 years, that is about 28% of the population. Now, why is this very, very important? Children in particular are the population that have an extraordinarily high degree of transmission of all respiratory pathogens, not just COVID-19. So even though children may not necessarily become very ill, they do acquire and transmit respiratory pathogens with much greater frequency, and they can go and give it to adults. So children may not get ill, but when they give it to adults, the infection in adults is deadly. So classic examples of this are mycoplasma and chickenpox. Now, the problem here is that because of the lack of immunization in children, schooling of children is a huge problem, particularly in India. We don't have the ability to seriously provide adequate long-distance learning through the internet for all the children in India. This is simply a fantasy. Now, what we need to think about is how can we take care of the entire affected people in the community rather than the hospital, for 3 reasons. In India, 65% of the population is rural with negligible access to adequate medical care. And we do not have enough capacity in public hospitals to handle the huge burden. Private hospitals are not an option for the average Indian citizen, even in urban areas. And concentrating large numbers of infected people in small areas, particularly poorly ventilated areas, increases the risk of transmission to other people, particularly healthcare providers, and increases the probability of emergence of yet newer variants of concern because of the fact that COVID-19 is a viral quasi-species and rapidly evolves into a genetically heterogeneous group of populations. So what the problem is that we need to have a plan to address not only the acute illness by COVID-19, but also the socioeconomic impact of the illness of the patient and the family, the socioeconomic impacts of lockdowns, and then the long-term impact of COVID-19, lung damage, emerging infections like tuberculosis and fungal infections, because COVID is a profoundly immunosuppressive infection. Long-term complications of inappropriate treatment regimens for COVID, like overzealous use of high-dose steroids, tocilizumab, remdesivir, ivermectin, and convalescent plasma. And then the long-term disability caused by COVID and the consequent loss of ability to earn a livelihood. Now, vaccine. Now, what is topical about vaccine is boosters. Why should we take a booster? Before we even go there, I'd like to tell you that I took my booster because I'm a healthcare professional and I consider myself somebody at high risk for getting into trouble. So I took the initial course of the Pfizer-BioNTech mRNA vaccine in December and January. And most recently, this past month, I took my booster. Now, here's a study from the Lancet that has a very nice discussion about vaccines and boosters. And what we can see is that by and large, the vaccines continue to be very effective against most variants, including the Delta variant. And the mRNA vaccine, as well as the other vaccines, are relatively comparable in efficacy. You have to be careful about making a huge distinction between a 90% efficacy versus a 70% efficacy, because the way the efficacy is determined is determining at the time of the studies, what is the background level of prevalence of infection in the population. So the fact that mRNA vaccines showed greater than 90% efficacy is really due to the fact that at the time that they were tested, there was a pretty high background prevalence of infection in the population. By the time the other vaccines were tested, the background prevalence had declined somewhat, and therefore you see a slightly smaller level of efficacy reported. But by and large, it doesn't really matter, because practically all vaccines are essentially equivalent in the way they give protection. In particular, all vaccines appear to protect people from dying. They may have less efficacy in protecting from actual infection, but they do protect people from dying, and they also reduce the rate of infection to other people. So a vaccinated individual, when he or she gets infected, is less likely to transmit that infection to other people as compared to an unvaccinated individual. Now, the boosters. Probably the best data comes from the transplant patients, which is published in the New England Journal of Medicine. And anecdotally, since I am part of the transplant listserv, I've been, the party to all of the conversations that my colleagues in transplant infectious disease have been having about what's going on with the transplant patient. And what was very clear right from the beginning is all of the transplant patients, solid organ, whatever, have a much higher morbidity and mortality due to COVID-19 despite vaccination. And as a corollary to that, if you look at the antibody responses after 2 doses, they are substantially lower than the general population. What is very gratifying is that 1 month after the booster, the third dose, there is a very gratifying increase in the amount of antibody response. Now, of course, this is debated a great deal because an antibody in and of itself is not the entire answer for a protective efficacy for vaccine. Nevertheless, in the transplant population, we have seen a decline in morbidity and mortality in the population that has received boosters. Now, the data from Israel, which is a countrywide data, shows that with the booster dose, the efficacy against confirmed infection is 11 times greater than just the standard 2 dose, and against severe illness is 15 times protected. Now, the criticism of this study is that the duration of follow-up was very, very short. So we don't really know, we do not have proof that boosters are really all that beneficial compared to a standard 2 dose in long-term follow-up in terms of the complete total protection against COVID-19 infection. Nevertheless, the data that we have seen to date is strongly suggestive that boosters do have protective efficacy, particularly in those people who are most vulnerable to COVID-19 illness and death, namely the immunocompromised. And this is precisely the population where vaccine as well as antiviral drugs seem to fail. Again, it is like Karna's Brahmastra. At the time of your greatest need, your greatest weapon fails you. Now, pediatric children's vaccine. So in Pfizer BioNTech, which actually was the first group that started studying vaccine in the pediatric age group, starting from the adolescents in 12 to 15 years of age, and demonstrated efficacy and has submitted that data. And I think that they have already received approval, if I'm not mistaken. They also have a 1, 2, 3 dose escalation study in much younger children, 6 months to 11 years old. And once that data comes through, that I think will give a lot of comfort to people who want children to be vaccinated. I have previously discussed the importance of vaccinating children. In India, the Zydus vaccine is approved for 12 years and above. The Covaxin was recommended for approval by the expert group. So now that is in the hands of the CDSA. Whether or not the Drug Controller General of India will approve the vaccine remains to be seen. I personally think that just having a vaccine is not enough. The challenge for India, despite the fact that we have managed to vaccinate 95 crore people in India, is really to have a uniformly critical mass vaccinated across the entire country, in both rural and urban areas, in adults as well as in children. But India at least has done a reasonably decent job in vaccinating with 2 doses the healthcare workers and other frontline workers. So that I think is really, really commendable, and really kudos to how India has used digital platforms and technology to really drive a massive vaccination campaign that is the envy of the entire world. So I will stop here and take questions.
Thank you, Dr. Vijay. Thank you very much. It was a wonderful insight about. You have just covered all the aspects. So, Dr. Pankaj, are you here? So let me hear. I think
Dr. Ruby, I would interrupt Dr. Ruby. We have a wonderful panelist, Dr. Atul Patel. I think we all know him, but because he's a guest today, he should also be introduced and he should be welcomed properly. And I request you to kindly say a few words about him. I really thank you, Dr. Atul Patel. Your previous updates have gone a long way in educating the people, educating the doctors all across, and they have been wonderful in treating the patients and in guiding us in treating the patients during the second wave. A large number of the doctors benefited, and large number of the patients ultimately got better treatment by virtue of your knowledge sharing on this platform. And we welcome you again. A formal introduction by Dr. Ruby, please.
Yeah, sure. Dr. Atul Patel, he's a MD and fellow FIDSA. He's a director, Department of Infectious Disease, Sterling Hospital, Ahmedabad. He's a visiting associate professor of medicine, Division of Infectious Disease, USF Tampa, Florida, USA. He is a founding member, Asia Fungal Working Group and the Fungal Infection Society Forum, Study Forum. He authored the current global guidance on the mucormycosis published in the Lancet Infectious Disease. He is currently conducting a multi-center study on the mucormycosis in COVID-19 patient in India. And he is a member of COVID Task Force, Gujarat State Scientific Committee, ICMR, and the Antiviral Committee of the ICMR. So, Dr. Patel, definitely you're most welcome.
And he's an international speaker. We have heard him many times from the UK platform also.
Many countries to teach. He's a great teacher, and every time, he's doing a lot of work for HIV also. So I know him from the HIV forums. So for this so many years. So and every time his talk, listening to his talk is something. It is always mesmerizing. So Dr. Patel, your inputs, and we have in the panelists. I will just complete the panel introduction. So Dr. S.K. Gupta already, Dr. Pankaj Chaudhary, he don't need any introduction. He is going to every day. He is updating on the EDPA forum all the new thing, all the updated thing in the early morning. If you open your WhatsApp, the first thing is the Dr. S.K. Gupta's COVID update. And we have in the panel Dr. Alok Gupta also. He's a pediatrician, a good friend, and he's a director of the Life Hospital, which is in Indrapuram, Delhi NCR region. So Dr. Atul Gupta, you are also welcome. So we welcomed all our panelists, and now we can start the discussion, and we will listen. We have just listened to Dr. Vijay Aldandi, and now I think Dr. Atul Patel, we would like your inputs on the same topic.
Yes, thank you very much for introduction. And I think Dr. Vijay has covered almost all the important points that we should know about COVID infections as well as the COVID vaccination. So I think I'm not going to add anything to what Dr. Vijay has told us. But I mean, he rightly said that we need the booster dose, extremely important because all of us are healthcare worker and coming in contact with the patients. But when we talk about the India, so two important questions comes when we talk about the booster dose. One is like when. So this when is extremely important because if you have listened Dr. Vijay's talk carefully, he has said that we need to vaccinate more than 75% of our Indian population. That means like we have to vaccinate almost like we have 130 million population. So I think 70% of it is a huge number. So almost 90 million people. And so far, like the one vaccine dose in India, almost more than 70 million people have received at least one dose, and around 28 million they have received a 2-dose vaccine. So fully vaccinated are still less, right?
Yes,
so our first priority should be to vaccinate the remaining population. So rather than, I mean, having a booster dose and taking a vaccine for those who are still waiting for their vaccination turn, I think we should give a priority to a persons who are still not vaccinated. This is extremely important. So I think when we try to discuss about when we should take a vaccine, I think again, we need to prioritize. So those who are at a high risk, they should receive a priority because most of us, like the doctors, we have started receiving first dose in the 15th Jan, and most of us has completed the second dose in the month of February. Right, so almost a year, almost nearly a year has been passed. So again, like we have to prioritize for a booster dose. And currently, the WHO has clearly says that those immunocompromised hosts should be receiving the booster dose. Right, so this is what the clarity that we have from WHO also. So when I think we need to find out the appropriate time for healthcare worker, our priority should be to give vaccination to the remaining population. This is extremely important. And Dr. Vijay has rightly said that pediatric population, still we do not have a good vaccine for pediatrics, though we have studies for Zydus vaccine and Covaxin. People are also doing, they have also done a study in pediatric patients waiting for their approval. So priority should be given to pediatric patients too. This is very important because schooling, if we want to open up the school across the urban and the rural area, we need to vaccinate our kids or the pediatric population. This is extremely important to curtail the ongoing COVID infections. And now the second question comes, which vaccine? Because for US, the doctors and the US population, it's very easy for them to, even if they have taken a Pfizer or the Moderna vaccine, they can have a booster dose with the same vaccine. I don't see any significant issues when they are taking a booster dose with the same vaccine. But we have a challenge here. There is a technical challenge, and we need to find out a good answer of that technical challenge because majority of us has received a Covishield vaccine. And if you analyze the Covishield vaccine, it is a chimpanzee adenovirus vector-based vaccine. So chimpanzee adenovirus is used to deliver the antigen into the human to produce his appropriate antibodies against that. And the reason for selections of chimpanzee adenovirus is that most of us have experienced the human adenovirus infections from childhood to the adulthood, and most of us are having antibodies against this human adenovirus, and that's going to neutralize. So it can definitely affect the delivery of antigen. The antigen that we would like to deliver will be neutralized by the antibodies against our human adenovirus. Now coming to our Covishield vaccine. So when we have received a 2 dose of chimpanzee adenovirus vaccine, though the companies claim that this is a non-replicating virus, so this chimpanzee adenovirus is not replicating, but still we are using the antigen. So there are chances that we may end up in development of antibodies against this chimpanzee adenovirus. Though we need a good study, good data on this, but it is possible that if we are taking a 3rd dose with the same chimpanzee adenovirus vector-based vaccine, there is a possibility that we may neutralize immediately with the productions of antibody because of the prior 2 dosage of this adenovirus. And that may affect the delivery of the antigen. So this is a theoretical possibility, but it's very important that we need to find out a good answer of this, that whether the antibodies are developed against this non-replicating virus. This is number 1. And the antibodies which has already developed against this chimpanzee adenovirus will be able to neutralize the 3rd dose or the booster dose that we are going to take with the same vaccine. But when I looked at the studies performed in the Europe where they have mixed and matched, so they have received the Covishield and followed by that is the AstraZeneca vaccine followed by the Pfizer. So they mix and match the mRNA versus vector based, and they found a good antibody response, right? So I think, I mean, in India, we should also think in terms of changing a vaccine, though we need to do a good small pilot studies about this, using a booster dose with the Covishield, using a booster dose with mRNA, either Moderna or the Pfizer vaccine. And then we need to find out, like, because still we have a time, because we need to vaccinate the remaining population. So during this time, like if we can do a good study about using a booster dose with mRNA vaccine, using the same Covishield vaccine, and find out like what is antibody response, right? So this is how, like, so which vaccine, still we need a good information about which vaccine we are going to use to boost all of us. So this is the second question that comes into my mind.
Right. Thank you, Dr. Atul, for your expert comments. And I welcome Dr. Alok. Dr. Alok is a pediatrician and Dr. S. Gupta is always there. So my first question, Dr. Vijay. Dr. Vijay, we are just talking about 3rd wave because AIIMS data has already said that 3rd wave would come right in the month of, say, October, November. So what is the projection regarding this? Because it's a very important aspect, because festivities are on, on cards. So what do you think regarding the 3rd wave? And because people are now become a little casual, they started attending gatherings, and movie halls are being opening up, the schools are opening up. So what is your projection regarding 3rd wave, Dr. Vijay?
So I think the problem is that lots of people have lots of opinions. Nobody, I don't think that we can predict, okay? Prediction is a hazardous business, especially when it is about the future. But going by experience of prior epidemics, with such a high transmission or are not, okay? So you look at the influenza pandemic, for example, in 1918. The first year, it was exactly like the COVID pandemic. There was a substantial number of people affected, then it declined. So everybody's okay, the usual flu thing has gone up, has gone down. But it came back, and it came back with a vengeance. A much larger number of people affected, right? And COVID did exactly the same thing. So if you look at the logistic map equation that I showed you, if the R naught exceeds 3.4494, the epidemic becomes cyclical. The question is how large will be the troughs and how big will be the peaks, okay? And that we don't know. The other kicker here is that unlike the past where we had no vaccine, no treatment, other than non-pharmacologic interventions such as masking and physical distancing, this time in this epidemic, we have introduced both vaccine and drug therapy and a much more robust response, driven by high technology. So we have changed the way epidemics behave. Now, exactly what will happen is hard to predict, but I would suggest that, given the propensity of the virus to replicate into such high numbers, And given the fact that it becomes a quasi-species so quickly, we should prepare for this epidemic to become endemic, and we should prepare for it to become cyclical. So even if we have managed to vaccinate a critical mass of people, there always are going to be sporadic little outbreaks, particularly amongst the highly vulnerable group. So it behooves us to be very careful for the next few years until things settle down and we know exactly what's going to happen.
Thank you, Dr. Vijay, for your comments. My question to Dr. S. Gupta. Dr. S. Gupta, you've been closely observing all the issues, right? Regarding the booster dose, because lately, around 67% of countrymen received the first dose, and only 27% received the second dose. So, do you feel that the government is a priority right now to consider regarding third wave, especially in the highly, people that who are at risk, that like healthcare professionals. Israel, as Dr. Vijay rightly said, that they have started the program. In UAE also, that the people have actually started taking third dose of vaccine. So, what is your take on the booster dose in a country as of now, Dr. S. Gupta?
Thank you, Vijay. Thank you, Pankaj. You have basically hit the right chord. Our country, the number of healthcare workers is nearly 1 crore people, maybe even less. The immediate healthcare workers, and to issue 1 crore vaccines to all these people is not a very big number, particularly when a country has been exporting the vaccines now. Gone are the days when we were having the deficit of vaccines. Our country has the plenty of number of vaccines. Second, because we are the biggest producer of the vaccine in the world. Secondly, the right question is, do the healthcare workers really need the vaccine? The booster dose vaccination data, as said by Dr. Vijay, is robust in case of immunocompromised people. But it cannot be extrapolated to the healthcare workers. We are yet to show that the healthcare workers, they have good amount of breakthrough infections, and those breakthrough infections are lethal and they lead to the hospitalization. Whatever breakthrough infection studies were done were found to have mild infections, and none of them actually died. Most of these studies, they came from most of the corporate hospitals in May, June, when the second wave was receding. Now there are hardly any breakthrough infections because the pandemic has gone down. It is receding. And I really do not know whether we can really extrapolate the data from the Pfizer vaccine, the Covaxin and the Covishield vaccine, because we do not have the studies on these points again. The breakthrough infection data or the booster dose vaccination data about the Covaxin is undergoing a trial and the results are yet to be out. The main question here lies, most of the doctors, most of the friends have been asking, I want to go for a booster dose. It is basically an abundance of caution. Do we really need the booster dose? If we really need the booster dose, the government is going to give 1 crore vaccine to all of us. I really don't doubt the government's intention. Though we still have a lot of people who are yet to be vaccinated, but the healthcare professionals' health has been always a priority. I would come back to Dr. Vijay and Dr. Atul Patel. Can they really say it with as a definite answer that the Pfizer vaccine data can be extrapolated to the Covaxin? And do they have shown that the healthcare workers, they really need the vaccination at this point?
I don't know that we have evidence, right? I mean, like I said, even Israel study is a short-term study. So, and remember that we are using antibody titers as a surrogate marker for immunity. So actually a better data set to look at is the number of infections and mortality, okay? So the Israel data does appear to show a illness and mortality advantage, but that is a short-term study and short-term follow-up. There is a concern also, albeit, we don't know the exact magnitude, right, of a condition known as antibody-dependent enhancement. There may be instances where, you give vaccine and that actually makes things worse with the natural infection. So far, we haven't seen it, but it is a concern. The other issue is what happens to very rare disorders like myocarditis in young people, the thrombotic disorders of women with the vaccines, Guillain-Barré, and all of those things. So that data, although the preliminary data suggests that there is no overwhelming signal, I would say that we still need to gather more evidence, and rather than go about and say, okay, we know this for a fact, I always would prefer to present the data with all of the uncertainties to anybody so that people are making their own informed choices about exactly what they want to do. I would suggest to you that in immunocompromised hosts, the preponderance of evidence is that they should get a booster dose.
Thank you, Dr. Vijay, for your comment.
Dr. Patel, what is your take on this? Would you like to recommend co-vaccine takers to go for the third dose booster?
Yeah, absolutely. Because what we should understand from the COVID-19 illness is that this is a new science. This is number one, and we do not have adequate information to say confidently that yes, you have to do this and you have to do this. This is not possible because still all of the world, we are struggling with the new information. Virus is replicating with a high, the new variant of concerns or the mutations. And the important concern that we have from these new mutations would be that evading immune system. So this is how the virus build up the capacity to evade the immune system from a natural infection, as well as from the vaccine-induced antibody immunity, right? So this is how the virus would like to survive. And at the same time, the mankind is struggling to neutralize the replicating virus. And the important tool that we have to neutralize the virus by preventing the infection is the vaccine. Another important fact that we should understand, though we do not have good adequate supporting data, that the waning immune system following a vaccinations is very common. So we need to take influenza vaccines every yearly because of the new the influenza strain which will be circulating into the world. So that's why we need a new vaccine, as well as like we are also receiving in the same vaccine the swine flu vaccine, that is H1N1, novel H1N1. Why? Because the antibody that we have generated or the produced from the influenza vaccine over a period of months, there is a natural waning. So the antibody titer will fall down and will be unable to neutralize the subsequent infection. And that's the reason that we need to take a booster every year for influenza. So if we can extrapolate this, and we know that so far from the important mutations from the COVID virus, that is the most important mutation to me is a Delta variant, because it has major mutations into the N-terminal domain apart from the spike protein. And this N-terminal domain mutations is extremely important for immune evasions, and it will not the response to the prior antibodies, even convalescent plasma, and the patients are susceptible to get Delta infections. So I think if I extrapolate from the influenza to this other respiratory virus, that is COVID-19, I think to have a booster dose is a reasonable options. Though we need a study, we do have good study from the organ transplant recipient patients, but the healthcare workers, we are at a very high risk, and over a period of months, we also expect the decaying of the antibodies which we have produced in response to the vaccination. So I think to me, the booster dose is very important for the doctors and the other people also. This is very important. But coming to your question, like Covaxin, so we do not have data like Pfizer and other companies, they have generated very good data. But for Indian companies, I mean, this is a major, I think, the obstacles or the limitations that the Covaxin people or the Covishield, like we do not collect good information about the side effect also. Like there are so many cases of VITT following this Covishield vaccine. Even we have treated large number of patients who has thrombocytopenia and thrombosis following vaccinations. We do have the patient who has received a vaccine and followed by patient, this is a female patient who has developed the syndrome similar to granulomatous polyangiitis, necrotizing lesions into the pulmonary system. The ANCA becomes positive and requires full-fledged treatment for the granulomatous polyangiitis. And there are so many other weird side effects that we have witnessed, we have treated, and many of these patients who has thrombocytopenia thrombosis syndrome or the VITT, we have lost many patients. But I mean, unfortunately, like the medical system is not gathering all this important data on the vaccination effectiveness, super infection, the complications. I think we should collect all this information. We should analyze it properly, timely, and we should take a decision according to our response. We cannot rely heavily on the European countries and the United States to generate data and extrapolate those vaccines to our vaccines.
Thank you, Dr. Atul. Dr. Ruby, I think I invite Dr. Alok also for his comments. Dr. Alok, welcome to EDP Forum.
Thank you, Dr. Pankaj. Thank you, august audience. So I would like to add the question again. Dr. S.K. Gupta told that we can spare 1 crore doses. If government doesn't want to give the extra burden of booster to the existing health economy, if they ask us to buy it and get it done. So those who are those who have got Covishield, I just want to ask all 4 of us or 5 of us or all the audience, what should be the vaccine choice of vaccine if a person has received 2 doses of Covishield, and what should be the choice of vaccine if the person has received 2 doses of Covaxin.
Dr. Alok, before that, we can ask take on the questions. What is the experience of pediatric age group? Because people have felt that now the schools are opening up, and they are the most vulnerable population from 2 years to 18 years now. Okay, so I don't think so. They have not been exposed because in second wave, every person has been exposed. So I don't think so that children are being spared. But due to paucity of VAERS receptors, they didn't get the severe illness, and the mortality is very less in the pediatric age group. So what is hue and cry about vaccinating those children right now? Dr. Alok, your comments.
Thank you. Dr. Pankaj, मैं आपको एक एक्सपीरियंस शेयर करना चाहता हूँ. मैं बच्चे देख रहा था, न्यूबॉर्न बच्चा था मेरे पास 45-50 डेज का. वो मेरे पास फीवर पीक ऑफ कोविड में जब हम लोग वर्चुअल कंसल्टेशन कर रहे थे, उस समय भी वो हाई फीवर लेकर के आया, और समहाउ आई फेल्ट कि दिस इज नॉट नॉर्मल इलनेस जो मैं देखता हूँ. एंड 45 डेज के बच्चे में वो लोग कोविड का टेस्ट कराने में हेजिटेंट थे. तो मैंने उसका हिस्ट्री पूछा, तो हल्के हल्के पेरेंट्स भी सिम्टोमेटिक थे. तो पेरेंट्स का कराया तो अनफॉर्चुनेटली बोथ पेरेंट्स वाज कोविड पॉजिटिव. So because they came to me in the peak of this, and I suspected it and got it done, and we never got COVID vaccine test done for the 45 days old baby. So it means it was COVID infection for the baby also. So similarly, we have seen whole families getting fever. Few of them, especially in the second wave, few of them were getting tested, and most of them were considering that this is a COVID infection. So in my opinion, most of our children have developed have encountered the COVID infection. And as suggested by the previous, after the second wave, the third wave, the children will be affected. We pediatricians, IAP, and all pediatric forum has commented on that. We don't see that these children will be affected. Only exclusively children will be affected, because previously we were seeing Kawasaki-like syndrome, which we were seeing when after the second dose, we came across so many children who came like Kawasaki-like syndrome, which is, we call it PIMS, post-inflammatory syndrome, we call it. So now for last around 2 months, we have, none of us are seeing that kind of syndrome. And that's what I'm saying. We don't see that the pediatric population is more vulnerable. अभी डॉक्टर विजय ने सारा कवर कर लिया था वैक्सीनेशन में pediatric को लेकर के. He has already covered it. But Zycov is a DNA vaccine, and we don't have much experience about the DNA vaccines in pediatric population. And today we have already got approval from the DGSI for the Covaxin can be used for 2 years to 18 years.
Dr. Alok, very pertinent questions. Do you recommend this Covaxin vaccine to your patients?
Yes, I am. I have much more confidence on Covaxin as compared to the antigen or the chimpanzee vaccine, which we talked about. this may be a personal bias, because we pediatrician use killed vaccine since long. We are using it for long, and we have hardly have come across with any side effects or adverse effects after the killed vaccines.
Dr. Ruby, you can ask some questions, right?
Yeah, I was just I wanted to ask, sir, what is a drop in antibodies means ki drop in immunity? Is it correct? What about the T cell immunity? We are not.
We have already discussed it. The antibody titer we are measuring is not a true measurement of our antibody. Dr. Patel has rightly, or Dr. Vijay has already discussed that mortality and the sickness should be the criteria for effectiveness of the vaccine rather than this antibody titer.
No, yes, that's what I mean. Ki that also plays a role in deciding whether the booster is needed or not, because the T cell is something like the sleeping cells, and they might be get activated again after the exposure of the infection. What is your take, Dr. Vijay, sir?
In my
We
opinion,
again think that, as best as we know, for coronaviruses and in particular COVID-19, what seems to be most important is actually innate immunity, the first early interferon response. Because if you look at the older people who are hospitalized, particularly those who are very ill, somewhere around a little over 10% of them have autoantibodies to interferons, okay? And that may be the reason why there is a persistent replication and very high mortality in that age group. So this is a very complex area, so it's not simply a cell-mediated immunity that's important. And in the past, we used to think that innate immunity cannot be trained. That appears to be not true. Actually, innate immunity can be trained. And there is a way to boost innate immunity by prior exposure to the antigen. So for all of those reasons, I think, the vaccine becomes very important. Now, the concern with pediatric vaccine always was that children have a very robust immune response to many different things, okay? And the concern was, will we have a syndrome of antibody-dependent enhancement, as we see in dengue, for example? The first infection sensitizes, and then a heterologous serotype gets a hypersensitivity reaction and clinical illness. So fortunately, that has turned out to be not so true with COVID-19, right? But the very simplistic way of looking at immunity simply by measuring a neutralizing antibody titer is, I would say, less than the complete story.
Okay, sir, Dr. Patel, what is, thank you, Dr. Vijay. I think, that was the thing we were looking for. And what, Dr. Patel, about this gap of the two doses? Different vaccine has a different gap. Is there it's just because of the population size we want to cover, or whether it is appropriate? Like, if I mean to say, if we decide about the booster, so according healthcare worker, we have taken the second dose after 28 days, right? And now the people are taking after 86 days of the Covishield. So how we will define about these gaps, which is appropriate gap, or what the future should be there? What gap we are deciding in the future vaccinate population?
I think, again, this is a little difficult question, because, again, the answer should based on the good evidence, good supportive data that we don't have, right? But the only thing I can say about the increasing the duration between two doses in India, I think it should be based on some scientific evidences, because when this AstraZeneca did study, the second dose, they kept it at 28 days, and then they measured the efficacy or the effectiveness of the vaccines in terms of antibody productions and the prevention of the infections. And that's how the vaccine got an emergency authorization. But because in India is a populous country and we do not have that much production capacity to vaccinate the entire population in a short span. So just to increases the available dose to the unvaccinated people, probably I think that was the idea to increases the gap. So we can give first dose at least to large number of population. And when they found that, I mean, delaying a second dose probably is not going to affect the ultimate antibody productions or the response to the Covishield. So probably they may have come out with, even with this little supportive data, they might have increases the duration between these two doses. Now coming to the booster dose, again, I mean, this is a big question for India, because we need to vaccinate our the population first, and followed by the booster to the high priority persons like immunocompromised. So all organ transplant recipient patients are receiving monoclonal antibodies for their collagen disease or other immunocompromised conditions, or the hematological malignancy patients. I think they should receive a priority for their booster dose, so we can protect them. And of course, like healthcare worker, right? And coming to the antibodies, because one question was generated that the antibodies levels are going down or it comes to zero, and what about my booster dose? I mean, this is a question. So let me tell you that, I mean, though Dr. Vijay has already discussed about the cell-mediated immunity, the innate immune system, and our antibody, which is neutralizing antibody following vaccinations. But all these three, innate, the vaccine-induced neutralizing antibodies, and the memory cells, all these three components are playing extremely important role. And whatever you are measuring from a laboratory checkup, that is, you are just looking at antibodies or the IgG against spike protein, and that may not be a true estimations of your neutralizing antibodies. We are not looking at the memory cell response. And let me give you the real examples. My next door neighbor in my society, both are young, around 40, 42 years. And before 1.5 months, they traveled to Chennai and they came back to Ahmedabad, and they developed COVID infection. The wife developed COVID infection first. After 4 days of arrival from Chennai, both were vaccinated with Covishield full dose long back. And wife has fever and the sore throat and little bit of respiratory symptoms. On day one, when I checked the blood counts, the routine workup that we did, and I added the antibodies against spike protein, just to, I mean, check that how she has responded to the prior vaccination. Though antibody measurement is not recommended after vaccination to evaluate the efficacy of vaccine, it is not recommended. But I was curiosity, I just, I mean, requested antibody titer, and it was sky high, 164. So it was very high, but her neutrophil counts were high and the lymphocytes were very low. So she has markedly altered NLR, the neutrophil lymphocyte ratio. So I was a little bit worried, because right now we do not, I mean, admit in private hospitals. So patient will have to go to the government hospital for their further treatment. But we just observed her symptoms and continue with the paracetamol, no other medications. And over a period of 3 to 4 days, she has improved nicely, no further clinical worsening, and she has improved. 2 days after, her husband becomes positive. And this is a very important story. And again, I repeated the CBC and the COVID antibody to the husband also, around 42 years. He has also received 2 doses of Covishield. His antibody titer was 0. But NLR was excellent. Lymphocytes were 42%, so NLR was very good. It was 1:1. So I was happy. And again, he had a fever, high-grade fever for only 1 day, headache and some little bit of throat discomfort. Again, his fever and the symptoms lasted for 3 to 4 days. After 4 days, he has lost taste, smell, and the smell, and he recovered. On 11th day, he was tired that I cannot be in quarantine. I cannot remain in isolation. I have to go to work because I'm asymptomatic. I said, you can't go. You have to, I mean, as per the government, you have to be in isolation for 2 weeks time, so 3 further days. But he asked me to get reports again. So we repeated his blood workup, and I again added spike protein antibodies. And to my surprise, the IgG against spike protein on day 11 of his symptomatology was more than 400. And this is not a story when you take a first dose and the second dose, right? So antibody, the response is delayed even after natural infection. This is very important to understand from COVID. And even after vaccination, the antibody development is much delayed and it is slow. But on day 11, because he has received a full vaccination, on day 11, his spike protein antibody was more than 400, and he has also mild symptoms and loss of taste and the smell sensation. So from this case, I think at least we can say that the fully vaccinated patients, irrespective of their antibody titer, whether it was good or it was zero, probably the chances of getting a mild illness is much higher. So we have to recommend vaccinations to all. And even though the antibody titer that you are measuring now and receiving vaccines in the month of January and February, your titer is zero, I think nothing to worry. Just maintain a good, the isolation and the precautions to avoid infections. And whenever we get a chance to have a booster dose after good study, we should take it as soon as possible.
That's excellent, I would say. That's wonderful.
Perfect.
Okay, so I think Dr. Atul has given a very practical example, and I think that has sorted the queries that have been raised in this forum. Right. My question to Dr. S. Gupta, sir, you have raised a very pertinent issue regarding masks, because in the previous weeks we have have surge of influenza patients, URI symptoms despite of being used masks. So what is your comments on the use of mask further, like in preventing the further COVID infections? Because this has been a quite a issue regarding that, because now we have seen that people are not using masks in gatherings, and even in doctors community, right? When we go to meet ourselves, right, we just put our mask and just we meet as we were doing it. Dr. Alok, we had a meeting, an IME meeting, when almost 150 people were there and nobody was wearing masks. So I think what is what is your comment on that? And it's a very pertinent issue regarding the use of masks. Dr. S. Gupta, sir.
Thank you, Pankaj. You hit the right call. Like mask currently, like the infection rate in India is going down. Number of cases have gone down dramatically, and the disease has become pandemic to endemic. And I personally feel that we do not need masks now. And our experience has shown that Delhi had a very severe influenza infection, and influenza is a virus similar to the SARS virus. And the masks were not able to prevent the influenza infection. We had huge numbers of patients of influenza, and right now we are having like those number of influenza patients have gone down. So I personally think that the masks are being used out of abundance of caution. Government is not able to, like, government cannot do anything about, like, the government is to act with the abundance of caution. Government doesn't want it to be a rule, but people are fatigued with the mask, and I personally feel that using masks in this wave might be useful. But when the number of infections have gone down in society, using masks is a burden. Our nose and the mouth are meant to breathe the fresh air. We are not used to, like, God has not given us a natural mask. Whatever the mask is there inside, it is in the form of cilia in the nose, and that mask is a very effective mask. But like carrying on the mask right now in the hospital might be important, because in the hospital setting or in the crowded setting like in public transport, we might have even one single patient who might transmit the infection to larger people. But in the society as such, when the number of cases have gone down, the mask may not be essential. Now, it is like you may be asking somebody to carry a blanket even during the summers. During the winters, it was fine, but now it is the summertime. You may be cautious. When it blows windy, you might have a blanket, but not in the summer as such. So I really do not feel that the mask may be essential. And what I feel is that the government is collecting good amount of money from the car owners in the form of fines. And Dr. Vijay, you might not be knowing that in India, if a car owner inside the car and the window pane is rolled up, he is seen without mask and he is fined 2,000 rupees. And by this way, the Delhi government has collected nearly 1,126 crore rupees for 2 months back, and the figures might have gone high, and they have really recovered the entire amount from the car owners. Whatever they spent on the vaccines, they have recovered from the car owners. So it is more of a penalizing action without any real effect on the transmission of the virus.
I think this is a very interesting question that you raised, and I just like to tell you a few things that I learned. Some of this is published, some of it is not, so it's pertinent. Right in the beginning, one thing that we noticed is that in the beginning of the epidemic, despite the fact that healthcare professionals were garbed from head to toe with perfect PPE, a large number of them got infected. So that raised a question, how on earth does somebody who's wearing an N95 mask and is covered from head to toe, essentially in a space suit, get infected? And the answer there was that the air was heavily contaminated with a very high titer of virus, okay? Why does that happen? Now, we got sidetracked into all of these sterile debates about, is it, aerosol, is it airborne, is it droplet, blah, 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 blah. That was not as important as asking the question, what is the density of virus in the air? Because if the density is high enough, you can have a 95% HEPA filter, but 5% of the air that is going in is still contaminated. And if the virus is at very high concentrations in the ambient air, your 95%, your N95 is not going to protect you. So people actually did studies to study how much virus there was in the air. And it was enormous. And that data was quietly buried. A lot of hospitals, threatened people to say, look, this is not a scientific study, you better not publish it, and blah, blah, blah. So this is the issue. So why has that become a problem? Because the reality is that if you have a very efficient air handling system, okay, and by regulation in our operating theaters, we demand that there should be a minimum of 20 exchanges of air per hour, with at least 3 to 4 of those being outside fresh air. That is actually seems to be good enough to reduce the concentration of virus in the air and be protected. However, outside the operating theater, even though we recommend at least 6 to 8 exchanges, many places, and I'm talking about hospitals in the United States, do not have anywhere near that number of exchanges, okay? So that's the problem. And if you are in a cold country and you are simply recirculating the heated air, you can imagine that the air becomes heavily contaminated. So if you have heavily contaminated air, it doesn't really matter what kind of mask you use. So you start thinking the masks are irrelevant. Now, I would suggest to you that the masks are what I would call a red herring or a distraction from the real debate. The real debate should be about the adequacy of ventilation. If you are sitting in a large enough room and you have 2 doors and 2 windows open, like I have in my clinic, that is at least 40 exchanges of air per hour. So I'm fine. So if you have adequate ventilation, you dilute out all the air, your chances of getting an infection transmitted to you from another infected person with COVID is drastically reduced. However, if you are sitting in a poorly ventilated room and you are encountering an infected patient, even if you have an N95 mask, it's not going to be very helpful.
Thank you, Dr. Vijay, for your comments on that. I think before we conclude, I think we have a final comment on the use of booster, because today is the topic of booster vaccination. Dr. Atul, your final comment. So Dr. Alok has rightly said that if government doesn't allow the boosters for healthcare workers and they say, okay, you just buy and you just take it. So what is your advice to the healthcare workers like us regarding booster, and which vaccine to be taken, Dr. Atul?
So we have to take booster. So I don't see any doubt in taking a booster. So all of us need a booster. So that's clear as of now. But regarding like which vaccine to be taken for a booster, if somebody who has received Covaxin first and second dose, I think there is no technicality in taking a Covaxin as a booster dose, because it is the inactivated killed vaccine. So there is no issue with the vector and the antibodies against the vector. So I don't see any hesitancy in taking a Covaxin as a booster dose in a Covaxin recipient patients. But for Covishield, I think we need a little data, little information. And if the data is encouraging, then there is no harm in continuing with the Covishield in a patient who has received Covishield. But as of now, if we do not have data, then I'll be more comfortable to take mRNA when I have received Covishield as my first and second dose vaccine.
Right. Dr. Vijay, your final comment on booster. You have already taken it. We know that.
Yeah, and I will tell you that considering the fact that the Indian healthcare force is challenged, because we just, I mean, look, it's not even comparable to the Western world. The numbers of patients we handle, the density of patients, the physical structure of our hospitals with poor ventilation tells me that our healthcare workforce is at extraordinarily high risk. So I would echo what Dr. Patel said, is that take the vaccine, take the booster. And right now, if you've taken the primary series of Covishield, I would suggest you take the Covaxin.
Right. So I think before we conclude, Dr. S. Gupta, your final comments, because you've been closely observing all these issues regarding vaccine.
I personally feel that we need to have our own data rather than following US data. There is no convincing evidence that the healthcare workers are being affected. And Delta has already created havoc in India, and it is not like at least the adults, though the unvaccinated population, children, they might be affected in times to come, and we should have the priority vaccination of all those people who have been left behind and the children. And I personally feel that children vaccination is going to get opened up very shortly, maybe 1 billion doses, maybe another couple of days, a week or so. The government might open up the children vaccination. And this is the vaccine being approved by the Subject Expert Committee is one of the things in the series, and we might soon be seeing the vaccination for children coming up very, very shortly. Already we have 2 vaccines, the vaccine, and then we might be vaccination, very safe vaccine. As for the booster is concerned, it is a very big question that the government might allow somebody to purchase the vaccine free in the free market. We are not still in that stage. And I think the people should be confident that they have had 2 doses and they are still not in the wave. We are not in the wave. And in case the booster is required, I think government is going to allow you. And you will be the first priority by the government to be covered.
So, Dr. Ruby, now you can conclude because we have a lot of queries answered by the expert panelist. Or you can conclude and we can hand over to Dr. Ashok.
Yeah, definitely. I think it was a wonderful discussion, and we have cleared all the doubts about the booster and the pediatric vaccination. And I feel, I mean, whenever we get the chance, we should take the booster. Definitely, that is a very clear-cut message. And this is also very clear who has taken the Covishield, they have to change it to the mRNA vaccine, which is a Covaxin as of now in India. Since we don't have the Pfizer or Moderna, so we have the only choice with the Covaxin. And soon this might be available for the children also. So let's hope for the best. And thank you very much, Dr. Vijay. Thank you, Dr. Atul, Dr. S. Gupta. So it was a wonderful discussion. And I hope all the...
I think this book is, Ruby, this book is really in shape. I'm going to have it soon on the desk. And I'm thankful to EDPA for all the wonderful updates. Dr. Atul Patel, Dr. Vijay, and so many other experts in the past. And it is the culmination of all your talks that is there in this book. And we are going to distribute it free of cost to all the doctors all across India. Thank you very much.
Thank you.
Excellent, excellent, excellent.
So, Dr. Ashok.
And thank you, Dr. Alok, also for joining us.
Yeah, thank
you. A short, Dr. Ashok, you can conclude.
Yes, sir. Thank you, sir. It is wonderful, sir. Wonderful to hear from Dr. Vijay Dandi, sir. Masterly presentation and very well thoughts and situation analysis of COVID-19 in current scenario. And I thank all the panelists, Dr. Atul sir, Dr. S.K. Gupta sir, and Alok Gupta sir, for very wonderful discussion on the present scenario of pediatric vaccination as well as booster dose. And related queries have been very well addressed. Even I have taken the booster dose offline, and I think it is a good idea, and we all should take, because we are very much in with all sort of patients we are dealing, and sometimes protection we are having, sometimes may not. So it is very relevant in the question of booster aid to the healthcare professionals. And I also thank Dr. Pankaj Chandan Chaudhary and Dr. Ruby Bansal for conducting this session very well. And also I thank all the members of the East Delhi Physician Association and students for joining this wonderful 14 COVID EDPA COVID update.